This newly established program of the series of monthly webinars within the MEFOMP Academy. It's my great honor to host today the first lecture by Dr. Tinsu Pan, a very long collaborator and friend from the motion correction team. Dr. Pan is a professor of within the Department of Imaging Physics at the University of MD Anderson in Houston, Texas. He's a dual board certified in by both the American Board of Radiology and Diagnostic Medical Physics and by the American Board of Science in Nuclear Medicine, the ABSNM. He received his PhD in electrical engineering from the University of Michigan in Ann Arbor in 1991. Then he moved to the University of Massachusetts Medical Center, where he did his postdoctoral training in nuclear medicine. Then he stayed there for another 3 years, where he continued as a research faculty. Before moving to industry, he joined GE Healthcare in 1996 as a senior CT physicist till 2003, after which he moved to MD Anderson. Dr. Pan is, as far as I know, he's one of the most known people in the motion correction research area, in particular in cardiac CT and 4D CT. I personally had the great luxury to work and collaborate with him back in 2002 or 2003 to develop the motion correction in PET-CT. That was at the start of the PET-CT. He's still focusing his research on motion correction in both cardiac CT and motion correction in the thorax for PET-CT. He has about 150 papers, 14 patents, and 12 book chapters. Great achievements. So Dr. Pan will tell us today about his experience and research in data-driven gated PET-CT, free of misregistration artifacts. Dr. Pan, the microphone is yours. Please, everyone, if you have any questions, write it in the chat and we can try to go over as many questions as possible after the lecture. Dr. Pan?
Thank you, Dr. Neme. Thank you very much. I have an honor today to come here to present to you what we have been doing at MD Anderson, and this is a follow-up work 20 years ago that I did collaborate with Dr. Neme. We had a very wonderful time working together, and then I still enjoy doing this. And then since we are a cancer center, so whole body imaging is very important. And then we keep doing this correction, motion correction, misregistration correction. And then today I'll summarize what we have been doing so far. So the next one, next slide. Okay, so here are some learning objectives. So I will overview the advancements of PET-CT, and then we'll talk about causes of respiratory motion artifacts in PET-CT, and we'll touch on 4D PET, 4D CT, which have been around for 20 years. And then 4D CT is still very popular, but 4D PET is not that much because of the complexity. And we have moved on to DDG PET-CT at our institution to mitigate these artifacts. And I would like to just say that many of the examples I'll present today are from the GE PET-CT scanners. Primarily is because it has the free Cine-CT on the GE PET-CT and GE CT scanners, which make it easier to do motion management. Okay. So in terms of technology, many of these have been available on the PET-CT. So going from the photomultiplier tubes, cutting the detectors much smaller, and then going to the silicon photomultiplier tubes, and then not the tubes, silicon photomultiplier semiconductors. And the resolution, I think, we can reach 3 to 4 millimeter pixels. So this is what depends on how much money we want to spend. We can actually get it. It's not a problem. And also the geometric sensitivity, we go from 2D to 3D. So this is almost all the scanners are 3D now. And then the longer axial field of view, the detector becomes bigger and bigger from 15 centimeters now, 25 centimeters is average or maybe close to average, and maybe it'll be even bigger, 30, even higher number of centimeters. And time of flight acquisition is also very good. Now the time of flight, the timing resolution is getting better and better, and then the reconstruction is getting better and better. Another thing very important is data-driven gating, which is just based on the PET data alone, we can extract the data from cytogram data doing the principal component analysis, and we can extract the respiratory signals. One main thing that is missing from my perspective is the data-driven gated CT is missing. That's where I'm going to concentrate more because the company's perspective still data-driven gated PET, they do not consider much of the CT part, and I think it's a missing opportunity. So we look at the PET CT scan characteristics. Of course, if we have enough money, we just buy the long axial field of view. We can probably do a threshold, but for the most part, we are still doing free breathing. And free breathing will cause some CT because we know that the CT is acquired in sub-second, PET is in minutes. So sometimes we have this kind of skin flow artifacts. We know that the abdomen is moving, and we know the lung, the liver is moving, and then no one's liver is going to be like this. So if there's misregistration between CT and PET, it is almost always, in my perspective, the fault of CT. Many times I wrote a paper for review. Some reviewers objected to this, but I've seen enough. I almost want to say that it's always the fault of CT because PET is an average acquisition. It is not going to be impacted by irregular respiration. And most of the PET CT scans are actually very good, free of misregistration artifact, because most patients are light breathing. There's no lesion involved, and expiration is longer than inspiration, so which make it easier to register PET and CT. But we still have some probability of getting a misregistered PET CT. So here are just some examples that we had at ND Anderson. So you can see from the left to the right, we go from 6.5 centimeters misregistration. Here's a nodule here. It's a lung nodule, but you can see that this is the whole thing is very very distorted, and this is a 5.3 and 4.65, and there's a nodules that don't line up. One is PET, one is CT, and change like this. Here's another nodule here. So this is not something that we are proud of, but this is not something that most of the PET CT scanners are capable of fixing this. So we spend a lot of time trying to minimize these misregistration artifacts. And of course, for gating, for non-gating, there are two different strategies. So let's look at what kind of impact would that be. This was actually one of our patients, and this was the esophageal patient, cancer patient at the GE junction. And then you can see that this patient was after induction chemo to shrink the tumor at the GE junction of the esophagus. And then it's unfortunately that the regional data coming out was false negative with misregistration because you can see the nodule disappeared according to the radiologist after induction chemo. And then we did a correction on it. If we ensure the registration was correct, then the tumor came back and then it became true positive without misregistration. So what kind of impact would this be? This is you can see that the false negative treatment target is in the blue, and then the green is the new treatment target. So in radiation therapy perspective, it is very difficult for them to understand that if they have a wrong image, and then they would target the wrong tissue area. So this was one example. We actually, fortunately, we caught this, and actually the target was changed from blue to green. So potentially, if there was a misregistration in PET-CT, it could make a inaccurate diagnosis or inaccurate treatment target. And so let's go back to this in radiation therapy. Many people know about 4D CT. Actually, I was one of the early people working on this. So the first one I did in March 8th, 2002. I did this in Canada and visiting a customer. And then he was doing this animal study. And he was asking me how I can fix the motion. So I took some I just took some CT scans, took the CT scan data back. And then at each location, I just put an ROI at their location. And then you can see in here, let me see if I can. Oh, okay. So you can see at each location, I was taking a CT scan. And I put an ROI. And we can actually see respiratory motion. And then by combining the peak points here, here, and here, and I can make a face out of it. This is another face, the valley ones. And then with that, then I was able to do this 6 centimeters in a table direction. I was overjoyed. It was I was very happy to see things like this because now we can kind of by hands. This is the data-driven gating, just based on the data itself. We can do it. And it took another 2 years to get it commercialized to do like this. So we get a CT scans and we combine it with the respiratory monitoring device, and then acquire the respiratory waveform, and then we put them all together to do some sorting, and then we can get a 4D CT. Oops, sorry. Let me do this. So, okay, somehow it doesn't want to move. Okay, so if we get a 4D CT like this, and then we can use the 4D CT to get a maximum intensity projection image and also every CT images. And it turned out to be these two are very useful in radiation therapy. In particular, this MIP. You can see the tumor motion envelope, and for the treatment dose calculation, this turned out to be very good. Every CT is a standard CT in our institution for dose calculation, in particular for proton, because you don't want to emphasize on any particular phase for proton therapy. So they use every CT for proton therapy. This dose calculation. And in the very early days, I suggest that maybe we can bypass all these sorting stuff. We can go directly from the CT image to the MIP and to the every CT. And we did some work, and then it turned out to be useful. And then, so in the center, if in case you don't have 4D CT, you have the CT, you can actually do very simple calculations, and you can get this MIP and see every CT images out. And the radiation dose for diagnostic purpose is only about less than 1.3 millisieverts. It's not big. And so in almost 20 years ago, so we use this concept of every CT. We get a CT image, we do an average, and then we get a small section of the anatomy, and we fuse with the whole body CT, and then we can get this every CT for attenuation correction of PET. I'm very happy to report that now every CT is standard and available on the GE, Siemens, and United Imaging PET-CT scanners. So you want to turn it on, they are available for you to play with. So every CT is a friend of PET because we do an averaging of the images, and then so it has the same temporal resolution as PET, and so it is available on these 3 different companies PET-CTs, and you can see on the conventional PET-CT, just for example, we have a lung nodule here, and then here's the heart, and then you can see a misregistration, And then if we do every CT, and you can see that the lesion line up, and you can see the heart line up. So this is from physics standpoint, every CT is better than helical CT, just in case if there's a misregistration. As I mentioned before, every CT was very good for dose calculation. This is our standard of care. We use every CT for dose calculation. Every CT also is very good for IGRT, image-guided radiation therapy. We are doing this every CT and combing CT alignment. Combing CT is from the LINAC therapy machine that you have therapy beam, and also you have the combing CT to get the images lining up the patient. And you can see on the left here is the every CT, on the right here is a combing CT. And then you can see that if we use this alignment, actually this is a standard of care in our center. So every CT has 3 applications. One for PET CT attenuation correction. The other one was for every CT for dose calculation. The other one is for, the third one is for every CT and combing CT alignment. And we can get this for free. We can just get the cine CT images, do an average, then we get it. One important aspect of this cine 4D CT was that it can do prospective. So basically, if you see, so here is a respiratory waveforms. You can see like this, and in case there was a patient irregular respiration, you can actually stop the acquisition. So this was on the GE scan panel. You can start scan, you can stop scan, and you can start scan again. So in here, incomplete, and then you can just resume when the respiratory waveform came back to normal, and you resume, and you can do this. Many people were not aware of this, but you can do it. So this is an inspiration. If we use this incorrect irregular respiration, you can see there was an artifact here. So this many ways that we can actually improve the 4D CT without buying a very expensive equipment. I mean, nowadays that Siemens has a perspective 4D CT, but that is maybe available in the last 2-3 years, and you need to buy the whole thing. It may not be necessary. So I would like to go back to Dr. Neyman's groundbreaking work almost 20 years ago, more than 20 years ago. So Dr. Neyman actually was the first one to do this 4D PET. So basically, we get the respiratory triggers, and we assign data to each data bin. So you can see that in here we have 8 bins, and then in the next cycle, we assign data to, and then over time, then we collect this different phases of PET data, and this is actually very good. The concept is very good. The only issue is in the implementation in the diagnostic imaging, because it is very cumbersome to do this, to do gating. I'll touch on that. And this was Dr. Neyman's paper 20 years ago. So it was very groundbreaking at that time. So hello? Okay. Okay, so here you can see that we have the gating reflector box here, and we have the monitor. This is a camera, and then you can see that at that time you can gate the PET data to get a better SUV reporting. This was actually eye-opening at that time. I mean, it's a very early stage, and we came to MD Anderson. We repeat this, and we were able to actually generate a very textbook like. I mean, you can see that 4D PET and 4D CT together, and you can see that this flat tabletop, infrared refractor, infrared camera, and it's good. We can do it, but it's just becoming very difficult to do it. So without gating, it's a 5.0 SUV. With gating 8.5. For this particular nodule, it is not making a difference, because it is 5.0, 8.5. They are all very high, and you can see that over the 6 pins, the tumor is moving and then moving up and moving down. So this can be done. And then for this particular case, we actually spent more than 45 minutes on the radiation oncology PET-CT. But it's just because it was difficult to do, and I'll explain that to you. So why is it challenge? There are so many challenges of external gating in PET-CT. So in radiation therapy, we can mount an infrared camera. We can ask the patient to unclothe, and then we can do all this without any problem. But in diagnostic imaging, it becomes very difficult. And most of the PET-CTs, at least in the US, are in diagnostic imaging. So you can see we put a warm blanket over the patient, and then we also make them feel comfortable. We have a knee cushion, and you can do. It's just becoming very difficult, and then you had very minimum contact between the refractor box and the patient's abdomen. So this is one of the major issues why today PET-CT is moving into the data-driven gated PET-CT. Okay.
Hello, we can't hear anything. Can you, Sadiq? I think he muted himself. It's being muted, and you are muted. Sadiq, you are muted as well.
Oh, okay. Sorry. I can unmute. Okay.
So you have to go back for.
Okay.
Back.
So what did you miss the previous one?
It's back, please.
From here?
No, back and
back.
Back, please. Thank you very much.
See. Let me how to go back.
If you can do. Let me
see. Oops, how can I go back? Okay.
Yes, from here.
Okay, so there are 3 different devices. We can do gating. They are all very standard. This is in radiation therapy. They are very familiar with this. This is the optical variant, Siemens optical device, and then this is the on-site strain gauge. It was by a Japanese company. It's a strain gauge, and then there's a Philips air bellows, and this is being used for quite some time. There's a tube here you can wrap around the patient. So these have been around for many years, and today my presentation is to tell you that there's no need for doing all these at all, because that we can get maybe even better than what we would do with the hardware gating. So if we have any misregistration issues, and certainly motion is another issue. If we have a misregistration issue in our clinic, this is what we were doing in the past. So we do a helical, the scalp scan, and we do a helical CT free breathing one, and we do a PET static. If there was a misregistration, then we would go back to do the abdomen, 1 to 2 bed acquisitions. So we do another CT, we do another PET. The main problem with this approach was that PET was not at fault. It was only the CT's fault. So there's there should be no need to do another PET. So in doing this, CT radiation dose was increased and scan time was increased. In general, it's about 5 to 10 minutes. And you can imagine that in a PET scan, you are talking about another 5 to 10 minutes extension of this PET CT. Then patient may not be comfortable. And so this was one of the examples. So this was a whole body PET CT finish. We have an artifact like this, and there was another repeat PET CT. And you can see that the two CTs were very different. However, the PET was about the same. So this was a kind of overkill, but this was what is available on the scanner, and you can always do repeat. But repeat itself is taking time. So I can give you an example why is the repeat PET CT could induce fatigue on the patient. So this was on the top is the baseline whole body PET CT, and you can see there was a big misregistration here, and then the patient's arms were up, and because at that time was okay. When the patient was told that you need to stay here for another 5 to 10 minutes, the patient made a complaint that it was just too hard to raise their arms up. So so the arms were down, and then you can see now we have another repeat PET CT. So it fixed this artifact. So my point here is that there was no fault on PET. It was just a fault on CT. There should be no point of taking another PET. And doing the repeat PET CT is not guaranteed that it will be better. So on the top here is the whole body PET CT, and you can see that we have a liver nodule here. And then when we do repeat PET CT, it was even worse. That was a repeat PET CT. The CT did not cooperate, and then we have another misregistration issue. So it is kind of hard because you are rolling dice twice. I mean, there's a good chance that you'll get it right, but in this case, it just did not make it right. So what I have proposed is that we should do conventional PET CT followed by a cine CT, a short cine CT. And so with this short cine CT, the radiation dose will be lower. Scan time will be shorter. So when I showed this to our clinic, and they were so excited, they jumped on it. And then just we had started doing this like 3 years ago. Now we have done more than 1,200 patients with this technique. And I compare also with the cine CT scan, radiation coverage, scan coverage, about one bed, about 14 centimeters. With the repeat PET CT, they are doing about 2 beds, like about 30 centimeters. So the scan coverage was much larger in the repeat PET CT than with cine CT. And in terms of effective radiation dose, cine CT was actually lower. And the mean is 1.3 millisieverts, and here you can see maybe average like 3 millisieverts. So you can see that not only did we save the time for misregistration correction, we also save the radiation dose. So this turned out to be a very effective solution that we have to combat this misregistration artifact. And on top of this, we can do also data-driven gated PET. So let me show you some examples. So here is the one nodule. We constantly do a lot of contrast injection, but you can see that in this particular nodule, it was kind of in the vessel. So it is kind of hard to imagine that FDG uptake in the vessel itself. And this is actually in the upper chest. The patient had a deep inspiration, and you can see that over here, then it becomes a nodule, a lymph node. So you can see that we corrected for it. So this was a 73-year-old man with a non-small cell lung cancer, and focal tracer uptake in the superior anterior mediastinum, projecting along the wall of the right subclavian vein, was initially interpreted as a non-specific vesicular. You can see that vesicular uptake, probably benign. After misregistration correction, this focus localized to a 0.7 centimeters lymph node and was later proven metastatic. So you can see that misregistration itself potentially could make a diagnosis inaccurate. And this was the comment from our physician reading this. It was painful. If they were looking at this image on the top, he had to hunt up the fusion translation tools and shift it around manually in his brain. I had another one that was badly registered. I had to spend a lot of time trying to improve it. So this was from one of our radiologists. I mean, so if they got a bad images, not a bad image, it's incorrect with artifacts, then they had to spend a lot of time trying to figure it out. So here was another example that a 65-year-old man with duodenal carcinoid tumor underwent gallium-68 DOTA PET CT for initial staging. In the first initial PET CT, there was no corresponding anatomies on the CT with these two nodules. Until we do an average PET CT correction, and then you can see that the two foci will not correlate with any corresponding CT abnormalities, but were correlated with two nodular wall thickenings in the proximal duodenum, corresponding to the known primary cancer in the average PET CT. Thus, the average PET CT provided important information for the clinical management of the patient to become a candidate for surgery. So this from our physician. So this actually proved that it can make a difference in terms of the diagnosis. So let's talk about data-driven gated PET. We are getting to the PET very exciting part. So with activity here, and then this is a center of mass approach by United Imaging. Different company is doing different things, but it's okay. I mean, they all have a similar concept, so they can track the activity in the dismal data, and they can follow up the tumor and then generate the respiratory waveforms and acquire respiratory signal from this center of mass calculation. And they can also do it for cardiac. This is very amazing. And then they can locate the heart motion, and they can actually also get a heart motion waveform. So this is actually very good. And GE, Siemens, United Imaging, they can all do this. And they are, I have experiences with the GE one, seems to be quite good too. So we're talking about data-driven gated PET. Now let's talking about data-driven gated CT that we have developed at MD Anderson. So this was published in 2022. And you can see that we do the Cine CT acquisition. This is free on any GE scanners. And once we get the data, we do a lung segmentation. We do a body contour segmentation. If it is lungs, we look for the CD number changes in the lungs. If there is no lungs, we look for the body contour variations. Then we can, in the end, we do some another checking. We get a data-driven gated CT, and then you can see that with this approach, we can give you baseline PET, baseline CT that was from the PET CT acquisition. We can give you the average CT. We can give you the N-inspiration CT. We can give you the N-inspiration CT. So with all these are going to be very helpful for radiation therapy treatment planning. And in here, not only did we get the average CT, we also get you the data-driven gated CT. And we can use the N-inspiration CT, which is closer to the PET average state. And we can generate these two CT and then from the whole body CT, and we do this. And this has been ongoing for about 3 years, and we have done more than 1,200 patients at MD Anderson. And some of the examples I showed you earlier, that was from this particular operation. How do we do this? We have 7 GE PET CT scanners in our shop, and then we have 3 in the outpatient, 1 in inpatient, and 3 satellites. And we basically, I use a computer which is about $100. It's very low cost. I mean, just a desktop computer, and then roll the software on this, and then on this server, and then it can interact with 7 PET CT scanners in our hospital network. So I would like to show you some of the examples. So the data-driven gated PET needs a data-driven gated CT for registration. So this is on the first column is the baseline. On the middle column is just a data-driven gated PET only. On the right is a data-driven gated PET plus data-driven gated CT. So you can see in the baseline, the registration was not ideal. You can see actually there are two different. These are two different patients, and here you can see PET activity was 7.15. If you do gating alone on PET, you get a 8.42. If you do gating on both PET and CT, 10.48. Okay, but for this one, we know this is a high uptake, and for this one, it's a 7.2, and then you can see 10.38, and you can see 14.34 after we do the both PET and CT gating. And I also, when I saw this case, this was also from our DDG CT correction. So you can see on the top here, this was original data, and it was diagnosed as inferior vena cava, had a high uptake. But once we corrected for it, then it goes to the liver. And then so the basic diagnosis goes from inferior vena cava to the liver. So motion correction was applied to the images. The focus increased radio tracer uptake that projected over the inferior vena cava described on the original report. So this was addendum. We have physicians making corrections on their data, on their report. It's now better defined, lies exclusively in the liver parenchyma at the margin of the hepatectomy. So you can see that misregistration, although many people did not pay attention to it, but it could make a difference in terms of diagnosis. And here's another example. So on the top here, the physician was presented to this set of images, and it was diagnosed that it was a liver lesion. And then after we done the correction on the bottom here, then you can see that actually this heart lesion was actually in the gallbladder and nothing to do with the liver. And you can see that there's also this hot spot actually is in a different in a tube, and so this is this hot spot is actually in the kidney. So after motion correction, there's evidence of normal tracer uptake in the gallbladder adjacent to the surgical sutures. So SUV was 6.9, associated with gallbladder wall thickening, as visualized on MRI, consistent with metastasis. There is no abnormal tracer uptake in the liver parenchyma. So imagine that this patient is with the original diagnosis, then you'll be called there was a liver metastasis, but in fact the patient did not have liver metastasis. You can see that on PET. I mean, this is kind of hard to tell because the gallbladder is actually adjacent to the liver, and you cannot tell is this in the liver or not in the liver. So here's the target. And we also have another example that a new lung nodule was called. You can see that there was some hint of tracer uptake. And then when we do both motion correction and misregistration correction, the new lung nodule was called. So it was a 0.9 centimeters pulmonary nodule in the lingula centrally FDG avid, and it's a maximum ICV of 5.9. This is stable compared to there's another CT scan, but new compared to this chest abdomen pelvis CT scan could be a metastatic nodule or an infectious nodule. So this particular one, I mean, with the corrections, although we can kind of see a hint here, but it was confirmed that there was something we need to follow up. So in the end, we can see that this has a very good and big applications for radiation therapy. So you can see on the left here is the baseline PET CT, okay? And you can see that there's one nodule here, there's another nodule here, but once we do gating, we can do data-driven gated PET CT. At end inspiration, you can see the end inspiration nodule at this location. Here's another nodule, here's a nodule, the same nodule. It was very obvious here, and you can see we can gate it in PET only. And you can see here, in the end expiration, and you can see end expiration. And then we can also generate maximum intensity projection to say that for the contouring. And then this is the end expiration CT, just to fill out the space. So this is I believe will be very useful for patients tumor contouring and also the motion management. Here's another example. So you can see the baseline here. We have one nodule here. You can see 2 spots because end expiration, and you can see a blurring. Once we do a motion correction, data-driven gated PET, data-driven gated CT, they line up, and then you can see that we can also gate the end expiration, so we can see these 2 nodules much clearer. And this is again, this is a PET, is a MIP, and is a end expiration DDG data-driven gated CT, and all these can be done in our particular setting in 15 minutes. Whole body PET CT, and then we follow with another acquisition of data-driven gated CT. Then it can be done in 15 minutes. So this is my kind of the take out of all these. So in the early days, since 2004, we started to do 4D CT. It took off. And now in radiation therapy, at least in the US, everybody is doing 4D CT. However, we struggled for almost 20 years with 4D PET, 4D PET CT. But as time goes on, when we started to launch data-driven gated PET, I think with the additional data-driven gated CT on top of data-driven gated PET to do data-driven gated PET CT, then we get rid of all these hardwares, and we can do it without any gating device, and we can get a data-driven gated PET CT free of misregistration and motion artifacts. This is kind of what I see the future is going to be. The less of hardware needed, but the more information we can get out of the data-driven gated PET CT in a whole body PET CT scan. So in summary, so I can just show you that in a summary here that this was the whole body PET CT. We can do it. The big tumor becomes 1, and you can see we can gate it. So we have developed a data-driven gated CT at MD Anderson, which is half of the CT radiation dose and save about 10 minutes per patient. So this was a big help for our clinic, and that's why we are doing data-driven gated CT. This is a standard of care in our center. When we see any misregistration, we immediately apply data-driven gated CT. And we can also go back to do the retrospective data-driven gated PET to register with data-driven gated CT to take care of both misregistration and tumor motion. So like in this case, the tumor motion and misregistration can be taken care of. And so in the future, I believe all radiation oncology PET CT can be free of misregistration, free of motion, and we can actually replace 4D CT with data-driven gated 4D CT. Then we don't need to use the hardware device to do the 4D CT. So we have done more than 1,200 patients at our center, and I believe that now is the time to get rid of the hardware gating device. And then in the end, I would like to acknowledge the contribution of our PET CT technologists. And I use extensively Ubuntu, Python, PyDicom, DICOM toolkit to develop this data-driven gated CT. Last but not least is the Cine CT. I really like the Cine CT. It's free, and we can just use it to our advantage. So thank you very much. Let me see any questions.
Thank you.
Sure.
Thank you. Very impressive results.
So let me look at the questions.
Okay.
Webinar recorded. Okay.
Please, if anyone has questions, please write it in the chat if you want. There are a couple of questions here. I have another question. I didn't type it, but I can read it.
Yeah, let me address this one. So there was a question from Rabi. For IGRT purposes, does every CT correlated with the free breathing combing CT? Yes, that's why we are using the every CT to align breathing combing CT, free breathing combing CT. That's a standard of care that we have. Sorry, there's no sound now. Mute. Okay, he's muted. We can't hear. Okay. 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 How does DDG PET-CT contribute to improved correction, particularly in case of irregular respiratory motion? Okay, so the purpose of DDG PET-CT is to correct for irregular respiratory motion. So in our center, when we see misregistration, we collect the Sydney CT and we do DDG CT and we correct for irregular respiratory motion. So, oops, sorry. I'm not sure what. Okay, so that's the whole purpose of this DDG CT. We correct for it in about 1 minute data acquisition, and it does not interfere with our patient workflow because we do each day 20 to 30 patients a day on one scanner. So if we have to take additional 10 minutes to do repeat scans, then that would not be ideal. And so the standard of care here is the DDG CT. So let me see. Okay, I think that I addressed all the chat.
Yeah, I have a question. So for the PET data-driven gating, you're deducing the signal from the lesion motion, correct?
So that was from the United Imaging one.
Right.
The GE one, they do not use it. They use a different approach. They call it principal component analysis.
Yeah, either way. So how do you handle this if you have multiple lesions in the same field of view and they move independently from each other? They can be in phase or out of phase or any combination.
So I this is a good question. That as far as I know, they use the let me see if I can actually they use this they calculate principal components of each particular sinogram. So out of that sinogram, they let me see if I can get you, maybe let me go back. Okay, so let me see. Okay, so this was the one that I used for our scanner. So this was a principal component analysis. So basically they calculate the principal components. So the majority of the information can be captured in the first principal component, second principal component, third principal component. So individual lesions are not counted individually. They look at the global. The global motion is in the superior inferior direction. And so you can see here there's a superior inferior direction, and then the first principal component is respiratory like. Okay. And then the second principal component may be cardiac, and the third one is kind of random. So they use this first respiratory, the principal component, and then they do it in the Fourier domain. They calculate there's a peak. That means that there's a frequency, strong frequency over there, and then over the kind of the compared to the background. If it is over a certain threshold, they kick in this respiratory gating. So individual nodules are not contributing to the signal that we are using for gating. It is a global one. The global one is a superior inferior direction, and then most of the tumor motions are in the superior inferior. So using that, I think is a reasonable approach, and it has been shown that it's actually quite good. So that would be my answer. Thank you, Sadek.
Okay. If I may, if no one has any other questions, I have one quick question. Can you comment on the role of machine learning for the correction?
Yes, I think that I'm also very interested in doing machine learning to do the correction. At this time, what I see is not very good. maybe the learning is not still maybe in the infant stage. I'm collaborating with a site that is very good in machine learning. They try to use this no correction data, no misregistration data, and then try to train this AI machine. And initial data I look at, we tried 30 patients. I throw in 30 of our patients into this algorithm. The initial results were not very good, but I'm still hopeful that they will make improvement. But another thing I'm looking at is that in the abdomen, it is very hard to, I don't know, like the examples I show, it is not easy for machine to learn. I mean, I would say let's go back to some of these. So things like this, it will be very hard for machine to learn because that they don't have the truth. And then most of the machine is learning this diaphragm, only the diaphragm. And then there will be some deformable registration. And then I'm not including some of those results here, but I see it's distorted. The images look fake. The rib cage was all, I mean, not quite like what human rib cage. I think that I should not badmouth on that, but I'm based on the initial result. We have an abstract to present in the SNNMI to talk about this. But right now, I mean, initial results I look at were not very promising at this time. But it can change. Thank you.
Thank you. Okay, we don't have any more questions. I would like to thank you, Dr. Tinsu, in behalf of the MEFOMP community. It was very informative. Before we close, can you please unshare your screen?
Okay, let me stop sharing. Okay, back.
All right, so before we close, just share my screen real quick. Can you see my screen?
Yes.
Okay. You can see my screen?
Yes, I can see your, no, not your screen. I can see everybody.
Okay, let me. Okay, so our next meeting, this is a monthly webinar. It's going to be again the last Monday of every month at 5:30 Mecca time, 10:30 New York time. Our next lecture is going to be on May 27.